بسم الله الرحمن الرحيم. الصلاة والسلام على سيدنا محمد عليه أفضل الصلاة والتسليم. السلام عليكم ورحمة الله وبركاته. اليوم هنتكلم على موضوع ارتفاع البوتاسيوم بالدم وخاصة بأمراض الكلى أو بمرضى الكلى. اليوم هنتكلم عن الهايبركاليميا practical approach, how you can diagnose and manage any patient came with hyperkalemia. Is this emergency or not, acute or chronic, and how you can deal with any patient with hyperkalemia. نحب نبدأ بس بالآية دي. بسم الله الرحمن الرحيم. وقل اعملوا فسهل الله عملكم ورسوله والمؤمنون. صدق الله العظيم. بسم الله الرحمن الرحيم. قال سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. اليوم هنبدأ our agenda today by different cases and how you can to evaluate and assess and manage your patient, and we will discuss later pathophysiology and physiology and the clinical picture and the final management of any patient with hyperkalemia. We'll start by case number 1. We have 76-year male patient came to emerge with diabetes, with no case of diabetes type 2 and oral hypoglycemic drugs. Also history of cabbage 1991, spontaneous heart failure 2005. His medication already the patient on enalapril, this is inhibitor 10 mg, and metoprolol 50 mg BID, spironolactone 50 once daily, and furosemide 60 BID. He started in Celebrex, non-steroidal anti-inflammatory for his back pain. 1 week later, he's weak and muscle stiffness. In summary, patient above 70 years came to emerge. He's known type 2 diabetes, cabbage, heart failure. He's already in enalapril, metoprolol, and spironolactone, furosemide, and Celebrex. And he came by weakness and muscle stiffness. When we saw his biochemistry, I found the potassium is around 8.3. I asked you to repeat, maybe homolize, maybe whatever. Just repeat it, came again is high, 7.7. This is true hyponatremia now. Creatinine for him 285, increased from baseline 150, and estimated GFR around 20 ml per minute. His sodium 137, chloride 111, and the bicarb is 16, metabolic acidosis, and hyperglycemia uncontrolled 18 millimole per liter. His blood glucose, random blood sugar. Now we have hyperkalemia, true hyperkalemia with CKD and metabolic acidosis and uncontrolled hyperglycemia. What is the first step of this patient? What is the first management? What I can, when I face this patient, or I need this consult for any patient like this, patient with potassium 7.7, with acidosis, with hyperglycemia, how you can manage and approach this patient. At the first step, put in your mind, this emergency or no, from where I know emergence. Adverse effect in hyperkalemia on an excitable tissue, heart and muscle, but mainly in hyperkalemia will concentrate in the heart because you will start sudden arrhythmia and maybe will go to sudden cardiac arrest. Muscle patient will came to, especially if in a hemodialysis patient, if you know a patient non-compliance and you came to emerge by muscle weakness and a little bit paralysis with hyperkalemia for patient with the dialysis, especially hemodialysis patient. But the main issue now is this patient is heart or cardiac effect of side effect from this hyperkalemia, sudden cardiac arrhythmia and this, and we'll discuss this. With our emergency, this patient is emergency or no from ECG and from your examination. Pathogenesis of hyperkalemia, we know hyperkalemia either from increase intake, patient taking high potassium diet, or shift out of the cells, or reduced kidney excretion of potassium. We have 3 ways how my patient develop hyperkalemia, either from non-compliance to his diet, he's taking all foods rich of potassium, and second, the differential diagnosis shift out of the cell. We'll see now from hyperglycemia or acidosis, whatever, and with reduced kidney secretion of the potassium, it is low GFR already. CKD is low estimated GFR. Factors contribute to hyperkalemia. As we said before, you should rule out intake, you should check your diet of your patient, but this is lowest probability for our patient with hyperkalemia emerge. Shift from cells, patient with insulin break, or lack. This insulin lack already, this patient with insulin deficiency, especially with type 1 diabetes. المريض بيبقى عنده نقص في الانسولين بخاصة مرضى السكر من النوع الأول. Or patient with non-anion gap metabolic acidosis. Non-anion gap metabolic acidosis, especially with type 4 RTA. Tissue necrosis ischemia, patient with hemolysis, potassium out of the cell, tumor lysis syndrome, potassium out of the cell, rhabdomyolysis, potassium out of the cell, transfusion of all the red blood cells already destructed, potassium out of the cell, with all tissue necrosis ischemia lead to hyperkalemia. This shift of insulin and non-anion gap metabolic acidosis, tissue necrosis ischemia, all this lead to non-anion gap metabolic acidosis. As third factor, kidney excretion of potassium. If we have patient with CKD with low GFR, he requires adequate sodium delivery. Any patient needs good sodium delivery, sodium to be in good amount to be exchanged in our inactive channel in our distal collecting tubule, collecting duct. If we have low GFR or proximal sodium reabsorption, increased already with low effective arterial blood volume, already reduced already with diuretic, all this will affect your sodium delivery to inactive channel in the connecting duct, and it will decrease already sodium reabsorption and the potassium excretion in our collecting duct. We need also aldosterone action, adequate hormone level, no drug antagonists like spironolactone. We need aldosterone action. Aldosterone will increase the potassium secretion and increase sodium reabsorption by activation of the inactive channel in collecting duct. This is the kidney excretion of the potassium, role of the kidney for potassium excretion. Distal flow. Why distal flow is important? Adequate delivery for sodium to ENaC to generate negative tubular lumen. You know, when we are given normal patient normal saline, or he's taking his regular diet with high salt, all this sodium will go to distal tubules or collecting tubules and will be reabsorbed via inactive channel, and this will make this sodium already positive charge will make the lumen sodium chloride will keep the chloride inside the tubular lumen and make the lumen more negative, and this will enhance the potassium secretion via room K channel to tubular lumen and will be excreted in urine. Higher sodium flow to collecting duct. If we have high sodium flow, this will increase the potassium in the lumen, as we discussed already. High flow activate PK channel. We have another potassium channel here. Her name is PK channel. This other class of potassium channel also, if activated, will lead to more potassium excretion. Our case analysis, our patient already lots, he taken, as regard the intake, when taken history, he taken lots of orange juice and the banana and the tomatoes and the pears and the peach. All this food high rich of potassium. Now, البرتقال, الموز, طماطم, all this are high rich food by potassium. We found our patient already non-compliant to this diet was rich of potassium. And the second issue for him shift, we have hyperglycemia because the lack of insulin. This patient already with diabetes with lack of insulin and hyperglycemia, this will enhance shift the potassium from intracellular to extracellular. And already metoprolol, this patient with selective beta blocker also will affect the action of aldosterone. And with non-anion gap metabolic acidosis, also this will, especially type 4 RTA, and we'll discuss all this pathogenesis in the next slide. And the renal excretion, this patient, our patient AKI and TOP-CKDs can increase from 150 to 200 plus, with estimated GFR less than 20 ml per minute. All this will affect our potassium secretion. This as regard to analyze your case. Any patient with hyperkalemia, you should check step by step. See your patient complies to diet or no. This is the first step. We have shift or no, blood sugar, medication, acid base. You should check this to diagnose your patient and reach to provisional diagnosis for your patient. And renal excretion, already we have biochemistry and the lab, you should check your kidney function. And estimated GFR already low, this will affect excretion of your potassium. Or any drugs affect your aldosterone action, like spironolactone or any other medication, as we'll discuss later. Drugs is impairing the potassium excretion. We have ACE inhibitor and the ARBs. All this will end by affect aldosterone action and secretion. And also the second mechanism, reducing GFR. This doing every vasodilator already will decrease your blood pressure and the low effective arterial blood volume. All this will affect the distal flow, and all this will affect your potassium excretion. Spironolactone is a competitive antagonist of aldosterone. We have the second drug, spironolactone, is already aldosterone inhibitor and lead to decrease potassium secretion and decrease also sodium reabsorption. We have the amiloride, trimetrin, and the trimethoprim. All this block the inactive channel in the collecting duct, and this inactive channel is responsible for reabsorption of sodium and excretion, and this will activate, will make your lumen is negative, and it will enhance potassium secretion from a room K channel. Prostaglandin inhibitor, like our patient is taking celebrexin and steroid, and already this will reduce the aldosterone. Aldosterone is responsible for sodium and water reabsorption and the potassium secretion. All this will impair in patient with prostaglandin, and also decrease the effective arterial blood volume by reducing the GFR, because this already will do aberrant vasoconstriction and reduce the distal sodium flow to a collecting duct and decrease sodium delivery to inactive channel and no more sodium reabsorption. And this will affect your sodium, your potassium secretion or excretion. Cyclosporin, we have this Winky kinase channel, and we'll discuss the CNI effect of hyperkalemia and hypertension in next slide. Case 1 summary, we have CKD, low GFR. This is the first step to cause hyperkalemia. We have polypharmacy, impaired potassium secretion. We have spironolactone, we have ramipril, we have beta blocker, selective beta blocker. We have already Celebrex also, and we have low GFR. Prostaglandin, as we mentioned already, this is non-steroidal, and hyperglycemia, metabolic acidosis. Insulin deficiency already shifted potassium out of the cell, and we'll discuss this mechanism later. And this patient with hyperglycemia and 909 gap metabolic acidosis with hyporeninemic, hypoaldosteronism. This also will lead to associated with hyperkalemia and with CKD. The causes of hyperkalemia in patients with diabetes. Insulin deficiency, hyporeninemic, hypoaldosteronism, and CKD with diabetes will enhance or increase the possibility for hyperkalemia, especially if the patient taking drugs ACE, spironolactone, and non-steroidal already. This is our summary for the first case. Case number 2, we have 31 on hemodialysis, 31 years old male patient on hemodialysis. عندنا مريض غسيل، مريض على غسيل كلوي, and his past medical history type 1 diabetes. Presented to emergency by paralysis, quadriplegia from home. He had been non-compliant with the insulin, his type 1 diabetes, non-compliance to his insulin, and diet past a few days. He already came by hypotension and bradycardia. Dialysis patient, non-compliance, hypotension, and bradycardia should think in hyperkalemia emergency, and adverse effect on your heart and muscle. Already our patient paralyzed and now hypotension, bradycardia. Well, this is ECG finding broad wide complex tachycardia, and this is the same ECG I found from this our textbook. Clinical manifestation, it's cardiac, our muscle weakness, our paralytic areas, all this, but paralytic areas I think is common with hypokalemia. We have cardiac and the muscle, we have peak T wave, peak narrow T wave, and flat B and the white chorus complex, and we'll go to sine wave and asystole after that. We have here just to show you this P wave or peak B wave, peak B wave, and the small or flat P wave, and we'll start to be white complex tachycardia. And here, this hemodialysis patient, potassium pre-dialysis and post-hemodialysis with white complex tachycardia. And this just here, B wave already start to be lower flat, white QRS complex, and peak the T wave. Peak narrow T wave to compare here or differentiate here from wide base hyperacute T of myocardial infarction. Our hyperkalemia patient will be narrow base and peaked T wave, narrow base. As we see here, if we have mild hyperkalemia 5.5 to 6.5, we'll have peaked T wave on narrow base with prolonged BR interval from 6.5 to 8. We'll show this white complex loss of B wave and P wave and prolonged QRS complex, and this ST segment elevation. Maybe we'll found ectopicalism also, and the severe more than 8 will found progressive widening of QRS complex, sine wave, ventricular fibrillation, asystole. And this will discuss all this, what is the mechanism of this, and how we cannot forget all this ECG finding of hyperkalemia. ECG changes with hyperkalemia. Take this message, please. This change extremely insensitive. Not all patients with hyperkalemia will come by ECG finding, hyperacute T wave or white QRS complex. Maybe the patient came with chronic hyperkalemia and came by potassium 7 or 8, and he will develop sudden arrhythmia and sudden cardiac death at any time. Just about this in your mind. Not all hyperkalemia, we should find this ECG change. This is insensitive already. And the poor correlation with the serum potassium, ECG may be normal or severe hyperkalemia. Fatal arrhythmia may occur without preceding typical ECG changes. Take care from this point. This is the most important message. Deal with hyperkalemia even without ECG changes, because it will lead to fatal arrhythmia. We have our lab for this patient. Our patient is this, to remind you, is a 31, hemodialysis, came by paralyzed, non-compliance, hypotension, bradycardia. This lab came by potassium 8.9, sodium 132, bicarbonate 14, chloride 106, and hyperglycemia 2, with creatinine because patient on dialysis. We have now this potassium 8.9 and bicarbonate 14 and blood sugar 24. Oh, how you can deal with this patient now in emergency hemodialysis patient? Especially if the problem with the patient anuric. This is a big problem with the patient anuric. What we'll do? Just why is this hyperkalemia happen? Because the intake, our patient non-compliance to low dietary potassium intake, and shift from hyperglycemia maybe, acidosis maybe also. This other factor, lack of insulin, this type 1 also enhance the shift. And the uremia has also decreased activity of sodium ATPase pump. All this contributed factor for shift for hyperkalemia. And you know the big problem if our patient hemodialysis and anuric. This is the 3 contributing factor for our hyperkalemia now. Either from intake, from shift, because the patient can control the blood sugar, and the other acidosis and uremia, and kidney function, your patient already in the stage renal disease. Emergency treatment in broad, I will discuss each one in details later. Emergency treatment of hyperkalemia. If I have a patient, hemodialysis patient, came to emerge with potassium more than 7, and with ECG changes or muscle paralysis, what I will do? The first step, stabilize your heart, calcium gluconate, around 10%, 1 gram, 2 gram, IV push, bolus, just to give push. Insulin, the second, the most important, the most effective line of treatment of hyperkalemia, insulin to shift potassium inside the cell. You will give dextrose 50%, 50 ml plus 10 unit actrapid or regular insulin, IV push over 10 minutes to 20 minutes. That's better, and better to be in safe side. Give insulin first, D5, do D50%, 50 ml, give him first, and then give attenuate for the risk of hypoglycemia, especially in elderly patients. And please don't forget to check your blood sugar 30 minutes, then maybe 20 minutes after, 30 minutes, 1 hour, to be sure your patient will have hypoglycemia. The most important complication of this line of treatment, follow your patient for hypoglycemia. Beta-2 agonist, we can give nebulizer, salbutamol, we can give all mentioned here around 20 milligram. But we already read before 5 to 10. And don't use this line of treatment if your patient has cardiac arrhythmia or history of cardiac disease. Beta-2 agonist, salbutamol, nebulizer, I will put 10 milligram plus 3 ml normal saline nebulized, maybe we'll repeat 3 or, but your patient under monitoring, close monitoring your patient for any arrhythmia. Just as regard the elimination of the potassium from your body, elimination from where? Either from urine or stool, GIT or kidney. If your kidney's function is okay, you can give normal saline if your patient looks volume depleted and hydration, split saturation is okay. I can give bolus normal saline of 500 or 250 or 1 liter as a patient urine, and you can give furosemide. All this will increase sodium, increase distal delivery of sodium to collecting tubules. Collecting tubule via inactive channel will take this sodium inside the cells and will make your tubular lumen negative because it takes sodium and keep chloride inside the lumen. The lumen now became negative, and this will activate the potassium to come from inside the cell via a Ronchi channel to a tubular lumen and to go to urine. As regards the binding resins like oxalate and other, I think not an emergency patient and high risk of bowel necrosis. Don't give oxalate without lactulose. We have now sodium zirconium. This is a new medication, local sachet, around 10 grams each sachet. We can give 10 grams every day or BID or if twice per week according to your patient, but with chronic patient, not with the emergency now. Insulin glucose, as we mentioned, just insulin stimulates sodium hydrogen antiporter, and we'll discuss this by diagram in the next slide later. This will stimulate sodium hydrogen antiporter. Sodium entry to the cells increase intracellular sodium. This will stimulate sodium ATPase. This is the issue for the mechanism of insulin will stimulate this channel or pores or opening. Sodium potassium antiporter channel. This will help sodium to inside the cells. This will stimulate sodium potassium ATPase and movement of potassium to the cell. And this will use the 50% 50 ml plus 10 unit rapid insulin, IV push, and glucose to be given to prevent hypoglycemia. Give the 50 first and then give the insulin. Onset of action will take around 15 minutes, 15 to 30 minutes to work, and the duration around 4 to 6 hours until you prepare your dialysis, hemodialysis machine. You just stabilize your patient. But don't forget you are doing shift only, not excretion by this method. And if your patient anuric, please just prepare urgent dialysis for him. Beta-2 agonist stimulates sodium potassium ATPase via cyclic adenosine monophosphate dependent pathway, and we'll discuss this also by diagrams. Also around 30 to 60 minutes, 30 to 60 minutes. Did the work after 30 minutes at least. About third of this patient no response. Sometimes I'm giving this medication but no benefit from this, and some patients respond. Just please avoid this in cardiac patient and the cardiac arrhythmia. Clear now. Just case 3, just a stable patient as our patient during nephrology clinic. We are facing this patient our clinic, 60 years, diabetes, type 2, hypertension, CKD3, A2, blood pressure 140 over 85 is the ramipril, 10 milligram statin, aspirin, amlodipine. This patient, our clinic is a common clinic case, creatinine 200, potassium 5.7, 5.5, 5.8, whatever. Bicarb 17 and proteinuria 1.5. It's a little bit acidotic. Hypokalemia, CKD with proteinuria, he need ramipril. Just will keep this ramipril. No, don't touch this. Any patient already CKD, don't touch because it will preserve your kidney function and will preserve your heart function, according to last trials and studies already on ACE and ARBs in patients with CKD. Even continue until patient started hemodialysis. Don't remove this at least. keep your cardio protection and keep your residual renal function working by keeping ACE or ARBs with your patient. This is an important message for you. Don't afraid from ACE or ARB because this will protect your kidney, not harm. This is a friend of the kidney, not harm to your kidney, and also heart, both. This is the most common cause of cardiac death in our renal patient is cardiovascular. Better to keep this ACE or ARB, whatever your GFR, even on dialysis, to protect the residual renal function and cardiovascular system. Treatment for outpatient hyperkalemia, not an emergency. Just pediatric counseling. Just advise your patient to what is high potassium diet and lead him to avoid this diet. This is the first step. If your patient not on Lasix, please start Lasix to increase distal flow for sodium and block your sodium potassium 2 chloride channel. When it's sick, ascending lane flow with heavily and the control also will help control your blood pressure. You know, hemodialysis patient and CKD, all these patients already blood pressure is high related to volume related, not other issue. And we have acidosis. We can start for our patient sodium bicarbonate 500 BID, 500 TID, 1 gram BID, 1 gram TID as your patient tolerated, and that will reduce the progression and increase potassium secretion. Please, if your patient in ACE or ARB, just continue this also to keep more residual renal function preservation and heart protection. Kexalate, we can give also Kexalate in our perfect patient 15 to 20 grams plus 30 to 50 ml lactulose. Why lactulose? Because it's Kexalate like cement, like زي الاسمنت بالظبط. ما تروحش تدعين Kexalate وتسيبه خلاص قفل اللارج انتستين وعمل لك نكروزس، فلازم ما تنسى تدي اللاكتولوز الكيكزاليت ومعاه لاكتولوز. غير كده ما تدعوا لارج اماونت اوف ووتر if your patient can tolerate. Localma, this is just recent, is a sodium zirconium recent resign also recently, but very nice dramatic response after you're giving your patient 1 or 2 sachets of 10 grams. Your patient will be dramatic response on that medication. We have this medication already available. And don't forget to educate your patient what is high potassium. Just don't forget this banana and this cantaloupe and this kiwi and mango and orange juice. And just try to look for this picture, and you can take and look and advise your patient. And if you have in your clinic or your center to print this picture like this colored one and giving to any patient with hyperkalemia, especially if you need to continue ACE or ARB with your patient, especially if CKD with proteinuria and the cardiovascular problem. Don't forget this avocado, banana, potatoes, citrus juice, also orange juice, all this high rich and fish already high rich of potassium. Again, don't forget, and our common food also, our dates, and this banana, this is the most common orange, lemon, fish, all this rich of potassium too. Just I put this picture if you like to just to remind you to give your patient in clinic picture like this, and try to remind you if you can put it in your clinic, at least to educate your patient and good counseling for low potassium diet. And this again, and this too. Case number 4 will start by 65 years old male, type 2 diabetes, ischemic heart disease. 65 male, type 2 diabetes, ischemic heart disease, and his usual medication for this hemodialysis, type 2 in IHD, in intermittent hemodialysis. His usual medication as hemodialysis patient and bisoprolol 7.5 milligram daily. He received the deceased donor kidney transplant and hemodialysis prior OR قبل العملية. عملنا له غسيل، كان البوتاسيوم بتاعه بعد الدياليسيس 4.5 ملي مول بر لتر. الOR تمام ومفيش أي مشاكل، no complication with the surgery and with good urine output even after this deceased kidney transplant. After surgery, when you go to PACU, this recovery room after surgery, you should check your biochemistry, analyze CBC, everything for your patient, vital sign, urine output. I found the potassium 7.2. Oh my God, what I will do now? What do you think? It is emergency or no? Just check your ECG, cardiac arrest, main ECG changes or respiratory weakness. As we mentioned before, we need to understand the side effect of this hyperkalemia on our cardiac muscle. Just we'll go to action potential, as we know from cardiology physiology before. We have this action potential will start by 0 stage or grade stage. Stage 0 is depolarization and will end by stage 3, this repolarization, and stage 4, this resting membrane potential. Our hyperkalemia, to understand from where hyperkalemia ECG changes came, just you should know this action potential because you are a nephrologist now. And we have rapid repolarization and slow depolarization. We'll start by rapid repolarization, stage 3. This will lead to hyperacute narrow T wave from a rapid depolarization from activation of potassium channel. We'll discuss this next. And hyperkalemia, second step, came from slow depolarization or slow impulse conduction. This slow depolarization, slow impulse conduction from slowing the impulse conduction from SA node to atrium, and this lead to flat or low P wave. And from SA node to AV node, this will be short PR interval. And from AV node to interventricular conduction system, either right bundle, left bundle, all this will lead to wide complex tachycardia. And this finally end by sine wave, ECG changes, and ventricular asystole. We know mechanism of hyperkalemia. I want to ask you, we have rapid repolarization, rapid hyperacute T wave, and the slow depolarization, flat or no P wave, absent, short PR interval, wide chorus complex. We'll start by stage 4, resting membrane potential. Our resting membrane potential is stable. We need potassium in and out in resting equilibrium state. When we have hyperkalemia, now our patient is negative and depolarized, lead to resting membrane potential less negative because we have hyperkalemia and depolarized, start to be depolarized, resting membrane potential. And depolarization means opening of fast sodium channel, and this lead to less opening of sodium channel and lead to slow depolarization and the slow impulse conduction, as we discussed before, and rapid depolarization from potassium efflux. And this hyperkalemia from increased conduction through this potassium channel and lead to potassium efflux out the cells and lead to rapid repolarization. Now our hyperkalemia, just this finally from this action potential, put in your mind just this slide. We have hyperkalemia means with rapid repolarization of stage 3 action potential, this lead to hyperacute narrow, hyperacute big narrow T wave in this rapid repolarization. And hyperkalemia with slow depolarization and the slow impulse and conduction, this with B wave absent or flat, BR short, wide chorus complex, and then sine wave asystole. These ECG changes, don't forget like this, as we learned from our Dr. Kamil, just the first step from rapid repolarization, this peaked narrow-based tint-shaped T wave and short acute T interval. This peaked narrow-based tint-shaped T wave with short acute T interval. This with rapid repolarization potassium efflux from intracellular to extracellular. Second step with depolarization, slow depolarization. There is an opening of fast sodium channel. We have broad or flat B wave. When this slow conduction from SA node to atrial muscle lead to flat B wave. Second step from SA node to AV node in cardiac physiology, this will lead to prolonged PR, I told short before this prolonged PR. And then will from AV node to cardiac muscle lead to, if slow conduction will lead to wide chorus complex, and then absent P wave, and then sine wave, and then asystole. يبقى we start by rapid repolarization and slow depolarization until asystole. Slow depolarization, slow conduction from LC node to cardiac muscle to atrial muscles, and then slow depolarization from LC node to AV node, and the slow depolarization from AV node to intraventricular conduction system, right bundle, left bundle, and then sine wave, and then asystole. It's clear now to understand what means by ECG signs of hyperkalemia as a nephrologist, not as a general internal medicine. Question number one: the hyperkalemia in this patient is due to pseudo hyperkalemia. Usually no ECG changes. We have, if you have ECG changes, not pseudo hyperkalemia. Pseudo hyperkalemia will not come by ECG changes. This decreased renal excretion, but this is acute problem now. This not AKI will keep this hyperkalemia like that. The main issue now for this patient is acute now, and post surgery you put in your mind this shift to potassium from ICF to extracellular fluid compartment. If we have any hyper patient with acute hyperkalemia post surgery, you should, this patient was the time period short? If yes, yes. Was the potassium input is low? We are not giving many patients post surgery or during surgery potassium, especially transplant. Our case, if yes, this will shift. If no, this renal problem or pseudo hyperkalemia. Our patient with this diagram now, potassium shift. We have already potassium inside the cells around 150 millimole per liter, and already outside the cells in extracellular, in our blood already we have maximum 5 millimole per liter. Why doesn't this potassium stay all this 150 millimole and 5 here outside? Why potassium stay here? The potassium stay here because we have intracellular fluid more negative by intracellular proteins, phosphoproteins, intracellular with negative charge, just this keeping pure potassium more inside the cells, not allowing to go outside the cell. Why potassium inside the cell 150 and outside the cells is 5, and why staying inside your cell? Because we have protein here, phosphoproteins is negative charge, just keeping your potassium inside the cell. And keep more, your lemon is negative, lead to some excretion of your potassium. By activation of this sodium potassium ATPase, you will export more positive charge. We have here 3 sodium out and 2 potassium inside. This keep intracellular fluid more negative, and the potassium stay intracellular. By this activation of this potassium, 3 sodium out, 2 potassium in, more positive out, and less positive in, this will keep your intracellular stay negative, and this will keep also your potassium inside the cell. Activation of ATPase channel to shift the potassium inside the cells. How is this mechanism? What is the mechanism of activation sodium potassium ATPase to shift the potassium inside the cell? We have increased the intracellular potassium. This is a rule. To activate this ATPase, you should increase this potassium. Increase affinity for sodium, like your sodium ATPase like or love sodium to activate this. More bump unit on cell surface. Just put more bump like ATPase pump or channels on cell surface. How you can do this? Number one, intracellular, increase the intracellular sodium. How can I increase the intracellular sodium? Bring more sodium inside the cell via activation this channel. I will bring more sodium inside the cells. Our first mechanism, increase the intracellular sodium to activate this channel to shift the potassium inside the cell. This is the mechanism now. Concentrate with me. What is the mechanism of how to can activate sodium potassium ATPase to shift the potassium inside the cells? Number one, increase intracellular sodium. How can I increase the intracellular sodium? By activation this sodium hydrogen antiporter channel. Sodium potassium antiporter channel. This will mix more sodium in and more hydrogen out. Okay, and this will activate your channel here. The second mechanism by insulin, bringing more sodium inside the cells by activating this sodium hydrogen channel. The sodium will be in and the hydrogen will be out by insulin. Insulin will cofactor for that, or will do that. Insulin will does that. This mechanism of insulin to shift the potassium. To shift the potassium inside the cell, bring more sodium to the intracellular and activate this sodium potassium ATPase. You know, this is insulin now, a mechanism of insulin now from this sodium hydrogen antiporter. This will increase your sodium to inside the cells, and this will activate sodium will increase here, will activate your sodium potassium ATPase, more potassium inside the cell. Second mechanism, increase affinity for sodium. This second mechanism to activate sodium potassium ATPase channel, as we mentioned before. Second mechanism, increase affinity for sodium by make sodium, make this sodium potassium ATPase love sodium by attach it to an alpha catalytic unit of a sodium ATPase. And we will attach this alpha sodium, will attach sodium to this alpha catalytic ATPase. This alpha catalytic, this FXYD proteins, this phospholamine. If you phosphorylate this, if you do phosphorylation for this phospholamine, FXYD1, it comes off. If you do phosphorylation for these proteins, it will come off, and sodium ATPase will be more active and start to pump sodium. Okay, you need to phosphorylate this by attaching to the unit of alpha catalytic enzyme by this phospholamine FXYD. You will mix this channel off, and this will activate sodium potassium ATPase. Also, same mechanism with beta-2 adrenergic agonist like salbutamol. Salbutamol will do phosphorylation or activation. This also the alpha catalytic unit of this enzyme FXYD1, and lead this or not working off. This will lead to activation of. This is a mechanism also of salbutamol or beta-2 agonist. How to increase potassium shift by activation sodium potassium ATPase channel. Also, another mechanism here for this FXYD phosphorylation and inhibition. Insulin also do this mechanism via a different pathway. Activate already this sodium hydrogen antiporter, bring more sodium inside the cells. Insulin, as we saw before, he activates sodium hydrogen antiporter, bring more sodium inside the cells, and phosphorylate phospholamine, this FXYD1, and at the end will activate sodium potassium ATPase. But the most important effective insulin that bring more sodium potassium ATPase from inside the cells to cell membrane or cell surface to increase the exchange with the sodium potassium, so via sodium potassium ATPase channel. This is the most important of insulin. You have to mechanism for insulin now, just will inhibit this phospholamine, and it will activate sodium potassium ATPase, and you will bring sodium ATPase from inside the cells to cell surface and will activate sodium potassium transport. And to remind you that your effective insulin not linked to this glucose transporter, no relation for this to affect our hypokalemia or not. Metabolic acidosis, just one question. Which one of the following statements correct regarding hyperkalemia in patient with DKA? Will just total body potassium is normal. Total body potassium increased due to volume contraction and concomitant oliguria. total body potassium is depleted due to osmotic diuresis, but serum potassium is elevated due to shift from intracellular due to metabolic acidosis, or total body potassium already depleted due to osmotic diuresis, this is okay, but serum potassium is elevated due to shift from intracellular due to insulin deficiency. I think this is the most correct answer. And why this is not correct? Because metabolic acidosis we'll discuss now. For this metabolic acidosis with decay, monocarboxyl, we have monocarboxylic acid like lactic acidosis with tissue hypoxemia, and then beta hydroxybutyrate from diabetic ketoacidosis. All this will not change this charge here, because we have here this will co-transport with the hydrogen already from extracellular to intracellular with no voltage difference, no change in the cell voltage, would not cause potassium shift. This monocarboxylic transporter channel co-transport both this anion and the cation already will be transported together, and this beta hydroxy came from lack of insulin already, and high potassium because shift not metabolic or lactic acidosis, but secondary to insulin deficiency, not related to metabolic or lactic acidosis. For this hyperosmolarity in extracellular fluid and this intracellular, especially patient post-kidney transplant and he receiving mannitol. Our doctor should give him mannitol after his transplant and during his surgery in OR room, or after neurosurgery, give him mannitol, especially in patient with neurosurgery and with high intracranial pressure. Because increases osmolarity here in extracellular fluid, this will lead to withdraw or drag water from intracellular to extracellular via an aquaporin channel. And this leads to high potassium concentration. For electrochemical equilibrium, potassium will leave intracellular to extracellular, lead to hyperkalemia. You understand now? In a patient receive mannitol or hyperglycemia, we have hyperosmolarity here. Hyperosmolarity will take water out, and this salt potassium will be high intracellular. For electrochemical equilibrium, potassium will go out and will lead to hyperkalemia. Post-operative, we have another two causes. We have alpha-adrenergic, patient pain, stress, stimulation of sympathetic nervous system. This will lead to potassium shift. This is another mechanism. And the other mechanism, alpha-adrenergic release, will stimulate also or inhibit the insulin release. This will lead to potassium shift because low insulin, hyperglycemia. What is the mechanism of lactic acidosis or tissue hypoxia, especially after exercise, exhausting exercise, seizure, tissue hypoxia? Lactic acidosis in the cell membrane, we have ATPs, potassium ATPs channel here, activated by this high ADP from exhausted exercise or seizure or tissue hypoxia inside the intracellular. Because this high ADP will be changed to ATP, when ADP increased, will lead to condition down, will activate this ATP's channel. When the high ADP will change to ATP and will activate this channel and will lead to more potassium out. البوتاسيوم what is the mechanism؟ سبحان الله، لما ظهرت الحته دي هتقول سبحان الله في لان البوتاسيوم اوريدي فازو دايليتر، هذا الميكانيزم كله حصل عشان البوتاسيوم يطلع يعمل لك فازو دايليتيشن في العيان اللي هو معاه تيشو هايبوكسيا. دي معجزه من معجزات ربنا سبحانه وتعالى، الحمد لله على الصحه والعافيه. فانت دلوقتي عندك يا سيدي exhausting exercise, seizure, tissue hypoxia lead to more lactic acidosis, more high ADP. High ADP will change it to ATP. ATP will activate this potassium ATPase channel, and more potassium outside. This potassium outside because this tissue hypoxia will lead to vasodilatation. Hyperkalemia shift, potassium shift. From where? What is the most common cause? We have trauma, post-surgery, whatever, rhabdomyolysis, tumor lysis, exhausting exercise, seizure, tissue hypoxia, all this lead to lactic acidosis, more ADP will activate ATP, potassium ATP, potassium outside cell, We have sodium potassium ATPase problems, lack of stimulus like insulin, no insulin, and beta-2 blocker also, presence of inhibitor dioxin overdose will inhibit this ATPase channel from dioxin overdose. Depolarizing agent succinylcholine also will lead to this potassium shift, hyperosmolarity, as we discussed, mannitol hyperglycemia, alpha adrenergic surge, post-surgery, metabolic acidosis, monocarboxylic acid patient with diarrhea or high normal saline intake also will lead to potassium shift, and hyperkalemic periodic paralysis also lead to potassium shift. We have now hyperkalemia. What is your time period? Is short or no? If short is yes, if no is renal. What is your potassium? If you're not taking any potassium through IV, if it's yes, it's shift. If it's no, it's renal problem. Just now, we need to how to reach it, to approach your patient with chronic hyperkalemia in your clinic. This pseudo or no, and we'll rule out pseudo. If patient pseudo, yes, okay, just repeat your potassium. If it no, just check your GFR. If it's low, yes, I don't know, related this hyperkalemia related to the GFR. If no, GFR decreased, check the medication. If yes, off this medication or try to modify or deal with your medication as needed. If it's no, check your effective arterial blood volume. If yes, if your patient volume depleted, if yes, with decreased electrogenic sodium reabsorption via inactive channel, and we'll discuss this later. If it's no, increase electroneutral sodium reabsorption, and we'll discuss this at the end. Pseudo hyperkalemia. The patient with fist clenching during blood sampling taking بيضغطوا له جامد، بيعملوا رباط ضغط كده علشان يبين العروق بتاعت الدم، فبيحصل عندك هيموليسيس. Or patient عنده thrombocytosis or leukocytosis, chronic lymphocytic leukemia, increased passive potassium permeability of red blood cells, pneumatic tube transport, cooling of the blood sample. All this lead to lysis of your red blood cells and lead to pseudo hyperkalemia. True chronic hyperkalemia is usually associated with hypercholoremic metabolic acidosis. True chronic hyperkalemia usually associated with hypercholoremic metabolic acidosis. Why? You have here this process stimulated by intracellular acidosis. We have here the cell, and this is the tubular lumen, proximal convoluted tubule, and this cells for proximal convoluted tubule. Here, glutamine, this amino acid glutamine metabolized to ammonium and bicarb. And then your body will get rid of this ammonium to urine and will keep this bicarb inside the lumen. How true chronic hyperkalemia is well as hypercholoremic metabolic acidosis in proximal convoluted tubules. This is the cells for proximal convoluted tubules, and this is a tubule. We have this amino acid glutamine will be metabolized to ammonium, and ammonium will get rid out to urine, and your body will retain your body will retain this bicarb. Inside this proximal tubules now will become more alkalotic, which inhibit renal ammoniogenesis. This inhibits any new bicarb formation, and this lead to hypercholoremic metabolic acidosis, lead to this true chronic hyperkalemia associated with hypercholoremic metabolic acidosis. And with our algorithm already we have chronic hyperkalemia patient. Is this patient pseudo? No. GFR is low, will come now to GFR less than 15. What is drugs interfere with the potassium excretion? You should know this medication. We have this already, aldosterone sensitive distal nephron in the collecting duct, and this is our principal cell. This is the most important cell for potassium regulation. And we have here sodium potassium antiporter, and this we have already here inactive channel and Romke channel. When we have sodium here, with high delivery to distal tubules. Sodium will be reabsorbed via an inactive channel, and keep the chloride here. This chloride will make this lumen more negative, and it will withdraw or draw potassium via Romke channel, and it lead to electroneutralization. Otherwise, if your sodium is low here, or this inactive channel is a have problem, or this Romke channel have problem, all this will lead to hyperkalemia. Renin will end by, as regards the metabolism of renin, will activate angiotensinogen to angiotensin 1 to angiotensin 2 to aldosterone. Aldosterone will act on the principal cells on the collecting duct. He will bind, the aldosterone will bind by his receptors, and the aldosterone receptor complex to bind to this nucleus. And this nucleus will end by transcription. This enzyme, serum glucocorticoid kinase 1, is responsible for inhibition and phosphorylation. This protein need for 2, because this need for 2 is his job to bring this inactive channel from the collecting duct to lysosome for degradation and destruction. We already now inhibit this by this serum glucocorticoid. From this diagram, you should know all the drugs that interfere with potassium and lead to hyperkalemia. Those drugs that inhibit renin, those drugs that inhibit angiotensin 2, those drugs that interfere with aldosterone, those drugs that interfere with this inactive channel, and we'll see. Drugs will intervene with renin, like direct renin blocker, non-steroidal drug inhibitors, is ARBs, drugs that inhibit aldosterone release, heparin and ketoconazole, drugs that block aldosterone receptor, spironolactone, iplerenone, drugs that block ENaC, this amiloride, trimetrin, trimesoprim, and bentamidine. This we are using in transplant patients with just 6-BP deficiency. Drugs that interfere with activation of ENaC by proteolytic cleavage, thus navametostat, this serine protease inhibitor. Forget this, we are not common, we are not dealing with this. Okay, just we need this medication. This is a common, this local ENaC channel, amiloride, trimetrin, trimesoprim, bentamidine. Don't forget this, amiloride, trimetrin, trimesoprim, bentamidine. These drugs block ENaC channel. Okay, this you should know all this. To be easy for you, will come from here. The drugs that impair the renin secretion, non-steroidal, beta blocker, cyclosporin, tacro, also diabetes, and the elderly. This direct renal inhibitors, alicycline, angiotensin 2, this RBS or RBS. Impair the aldosterone secretion, heparin, ketoconazole, adrenal disease, drugs that interfere with aldosterone receptors, spironolactone, iplerenone, like that. Drugs which deal with an ENaC channel, amiloride, trimetrin, trimesoprim, bentamidine. All this you should know, and I put in diagram. It is a nice diagram. This is a more clear diagram. These drugs that interfere with the renin, like non-steroidal, beta blocker, cyclosporin, tacrolimus, diabetes, elderly. This more, I think, is the best and the clear one. And angiotensin 2, just is or ARBs will control this. And impaired aldosterone mechanism, impaired and receptor blocker for aldosterone, impaired heparin and ketoconazole. Inhibition to heparin and ketoconazole was hyperkalemia. Thank you. This impaired aldosterone mechanism. Aldosterone receptor blocker, spironolactone, iplerenone, and others. And this ENaC channel, we have amiloride, trimetrin, trimesoprim, bactrin. We are giving post-transplant for prophylaxis for UTI, BGB. This trimesoprim lead to this hyperkalemia. Amiloride we are using already in patient with hypertension and patient with hypercalcemia. All this lead to hyperkalemia too. Bentamidine we are using as a prophylaxis if a patient with G6PD deficiency, especially for post-transplant patient, we are taking as a nebulizer each month, and this also will lead to hyperkalemia. Okay, and this is the same another diagram. And now we have chronic hyperkalemia. Rule out pseudo, not pseudo. GFR is low. We are in GFR is low. If it is not low, we'll check drugs. If no drugs, we'll check effective arterial blood volume. If the effective arterial blood volume is low, yes or no? If yes, decrease electrogenic sodium reabsorption, close the enam. We have no sodium now because low blood volume, population volume depletion, low sodium delivered to distal collecting adult to inactive channel. If the effective blood volume patient already blood pressure is okay and looks euvolemic, hypervolemic, this with increased electrogenic sodium reabsorption, active sodium chloride co-transporter channel in distal convoluted tubule. We have here aldosterone sensitive distal nephron. We have here inactive channel and Ronke channel, and sodium, potassium. Antiporter in principal cells, main cell. If you remember one cell, just remember this cell. And here, inactive channel will absorb more sodium and keep it more negative because chloride here lead to more positive potassium from inside cells to outside the cells. And here again, renin. Just to remind you, renin will lead by aldosterone receptors, the complex nucleus activates this transcript, this enzyme, serum serum glucocorticoid kinase 1 lead to inhibition phosphorylation lead 4-2, and this lead to activation of this channel because this already channel will be degraded by this, and this already inhibited by this serum glucocorticoid kinase 1. This electrogenic sodium reabsorption, hyperkalemia, and sodium wasting this mechanism will lead to, because low effective arterial blood volume will lead to hyperkalemia, and sodium wasting because low effective arterial blood volume. Less electrogenic sodium reabsorption, low effective arterial blood volume, your patient already volume depleted, decrease distal delivery of sodium and the distal flow to aldosterone sensitive distal nephron, and this will lead to hyperkalemia and as our patient, hyporenin, hypoaldosteronism. If we have juxtaglomeralar apparatus defect with hyporenin, hypoaldosteronism, or aldosterone problem, Addison disease, or inherited disorders, aldosterone senses problem, aldosterone receptor problem, pseudo-hypoaldosteronism type 1 autosomal dominant, or pseudo-hypoaldosteronism type 1 autosomal recessive if ENaC problem. Case number 5. We have one patient, a male patient, 55 years, type 2 diabetes and hypertension. He's in high hyperkalemia on ACE inhibitor, already discontinued, amlodipine and beta blocker current. And this blood pressure 160 is not hypovolemic. Blood pressure is high. And type 2 diabetes, hypertension, 55 years with GVB 3 centimeter is euvolemic, mild peripheral edema is hypervolemic. This blood pressure with this, all hypervolemic. Okay. Potassium 5.8, bicarbonate 19, creatinine 120, and the renin is low. Renin is low, aldosterone also a little bit low, CD 120. And then our diagnosis, hyporenin, hypoaldosteronism type 4 RT, because diabetes, hypertension, OAS, amlodipine, beta blocker, hypervolemic, and with metabolic acidosis, hyperkalemia, and the renin is low. This was hyporenemic, hypoaldosteronism type 4 RT. Among the following, what is the most appropriate management of this hyperkalemia in this patient? We will give fluoronef, or fludrocortisone, or thiazide diuretic for this patient. Take care. If my patient volume depleted and hypotension, and with this scenario, I will give fludrocortisone. If my patient hypertension and lower limb edema and hypervolemic, I will give thiazide. This will come here. We have low renin and low aldosterone, and this will end by high potassium because low renin and decrease the effective renin, because aldosterone will make this, will activate this channel ENaC and will lead to potassium secretion, sodium reabsorption, and because low renin, low aldosterone already will lead to hyperkalemia because decreased aldosterone, decreased potassium secretion, and no salt and water, sodium and water retention, this lead to effective arterial blood pressure. But NAD is high, furosemide, plasma renin increase. If you give furosemide, the plasma renin will increase because your patient hypervolemic. Hypervolemia now will suppress renin. If you give furosemide, will decrease the effective arterial blood volume and will increase renin. This already will happen with Gordon syndrome, pseudo-hyperaldosteronism type 2, or familial hypertension with hyperkalemia. Pseudo-hyperaldosteronism type 2, this is Gordon syndrome. Hyperkalemia, metabolic acidosis, and hypertension. This Gordon is a common exam question. Gordon syndrome, pseudo-hyperaldosteronism type 2, or familial hypertension with hyperkalemia, with patient hyperkalemia, metabolic acidosis, and hypertension. All from this Wink kinase with no lysine. Wink اختصار abbreviation for with no lysine. We have here Wink kinase phosphorylate. Wink kinase, what is this Wink kinase? It's the most important and tricky question for nephrologists. Wink kinase phosphorylate and activates this sodium chloride channel co-transporter channel on the distal convoluted tubule. يبقى الوينك كاينيز بتعمل لنا اكتيفيشن للصوديوم كلورايد كو-transporter channel on the distal convoluted tubule. أنا لما يحصل لي اكتيفيشن هنا ايه اللي بيحصل؟ بيحصل صوديوم reabsorption and decrease sodium delivery to collecting duct. This lead to decreased sodium reabsorption and decreased potassium secretion because the myelin not negative. Wink kinase phosphorylates this again, whatever the name, Wink4 or Link1, all this activates this channel, more sodium reabsorption and decreases sodium delivery to distant tubules. And the Wink kinase is doing another mechanism. What is the other mechanism? You know, ring key responsible for potassium from inside the cells to out the cells. This also the Wink kinase will take this ring key from cell surface here and make intracellular. Make endocytosis. It will be more difficult to excrete potassium and lead to hyperkalemia. يبقى الوينك كايناز بتعمل ايه؟ بتاخد الرونكي تدخلها جوه الخليه وبتنشط لك مين الصوديوم كلورايد بيقلل الصوديوم delivery to distant tubules. Wink kinase stimulate sodium chloride co-transporter in the distal convoluted tubules and lead to reabsorb more sodium. Reabsorb more sodium, lead to sodium chloride with water already and lead to extra effective arterial blood volume expansion and hypertension. This is number one. This is the mechanism of cyclosporine. And number two, this will lead to suppress renin and suppress aldosterone 2. This also lead to hyperkalemia. And this sodium reabsorption, this collecting duct, because the low delivery will be low and no potassium excretion. All this is the mechanism of this. We'll start from distal convoluted tubules because high sodium chloride reabsorption from activation sodium chloride co-transporter channel in distal convoluted tubules lead to less sodium delivery to collecting duct. No ENaC now not working, and the potassium will not found this negative charge here, and the potassium will keep inside the cell and lead to hyperkalemia, and the effective arterial blood volume will be high from sodium chloride reabsorption with water in the distal convoluted tubules. Hyperinsulinemia, if we have insulin, will activate also Wink kinase, and the Wink kinase will activate sodium chloride co-transporter. Same mechanism. This was hyperinsulinemia. And the same mechanism with calcineurin inhibitor will activate calcineurin Wink kinase on just will activate sodium chloride co-transporter distal convoluted tubules. Hyporenin, hypoaldosteronism. We have two types. If we have true juxtahumeral apparatus already problem, if we have clear problem, we'll have our patient effective arterial blood volume will be low, hypovolemic. I will give fludrocortisone for this patient. If my patient just functional from this Wink kinase, because the stimulation of sodium chloride or activation sodium chloride co-transporter channel, my effective arterial blood volume will be not low, will be high with hypertension and edema like our patient, and you should give your size. You should differentiate before you will manage your patient. Don't mention only just this diabetes hyperkalemia, just this RTA type 4 now. Just please look for this diagram. and decide you will give Florinef or thiazide, not both. Our patient, again, back to our patient. What's your management? I will give you my patient thiazide because already hypertension and the acid, you give him for cortisone was his case. Again, now this finish our diagram. Pseudo hyperkalemia, yes or no? If no, GFR, yes or no? Drugs, yes or no? Effective volume, yes or no? And decide to give thiazide or Florinef. Case number 6. I have 60 years old lady and stage renal disease. Old lady, end-stage renal disease. Just came to emerge feeling unwell and missed 2 dialysis session examination, blood pressure 90, hypertension, hypokalemia, saturation 92 mmHg, and respiratory she's tachypnea 28. Oh, creatinine 1,400, dialysis patient, not drug for creatinine. And if marker for poor dialysis already, no problem. And the potassium 8.5, bicarb 16, and the physician call you, Dr. Banasawi, call Dr. Abdelhamid. Oh, ECG, you should do, Dr. Banasawi, just don't wait for me to come to emerge. Maybe I'm busy in dialysis or first class insertion. Just deal with your patient. You are emerge doctor, you should do ECG. If he finds this changes, please interfere with your patient emergency. This sodium bicarb and do all anti-hyperkalemic as you can. And emergency, don't wait for nephrology to come. Maybe it will take 30 minutes and your patient will arrest in front of you. And you are emergency doctor. And just check your charisma or respiratory muscle weakness for your patient. If your patient already keep muscle fatigue, weakness, and the cardiac charisma, you'll see this easily in your ECG. What is the next appropriate treatment for this patient? Immediate dialysis. انت دلوقتي هتتصل بتاع الكلى عشان يجي يغسل العيان ولا تتعامل مع العيان تثبته الاول وبعدين ثبت المريض الاول يا عم سيف المريض اي بي سي يا ريس اديله كالسيوم الاول اعمل لي ستابلايزيشن للممبرين اديله ديكستروز 50 مع انسولين ديكستروز 50% 50 ml plus 10 unit regular insulin IV push calcium gluconate 1 or 2 gram IV push put your patient on monitoring during this and check your blood sugar after this. And arrange for dialysis because dialysis will take time to be arranged. I will not take the patient direct to put him in machine not ready. Maybe no available machine for him. Just deal with emergency as emergency case. There is no rule in emergency. Calcium gluconate, first step, then glucose insulin. Second patient, 65 years male patient, type 2 diabetes, CKD, creatinine 180, estimated GFR 33. Is referred for management CKD, blood pressure 160-100 or Ramipril 5 mg. This I think is another clinic patient. We have one patient in our clinic now with this potassium 5.5, creatinine 200, hypertension or Ramipril 5. What you would like to do next for this patient? I need every nephrology doctor before start RIAS and patient CKD, please give your patient just a little bit time and pamphlet or give him اي منشور عندك اي صوره تكون منزل عليها جميع الاكل او الوجبات بالرسم وبالصوره وبالكتابه وكل شيء. I need your patient to be fully educated for potassium diet. You should avoid any high potassium diet. And regard his cakes, this you can use as a chronic management, no problem, not the issue now. You will do glucose insulin shift is not emergency now, and this is just only 5.5 and the normal around 5.1, 5.3, no problem. Start to chlorosalidone for this patient. He's still hypertensive and already CKD and potassium 5.5 and already Ramipril 5. I think we have now the best choice for the patient. I can start for him chlorosalidone just to increase sodium delivery to the distal tubules. This will help to control the blood pressure because decreased sodium and water reabsorption will decrease the effective arterial volume expansion and will increase sodium delivery to the collecting duct. Will increase sodium reabsorption, potassium secretion. Is the best option now to deal with my patient. If not controlled on that, just please, as a first one, I will forget this because you already educate your patient for low potassium diet. And the second step, I can give him Xalate. He can give 15 gram, not milligram. 15 to 20 gram plus 30 ml lactulose together, maybe once every other day or twice per week to control your potassium and follow up your patient weekly or every 2 weeks until UP stabilize your patient in safe level of potassium. And this typical Western diet provide about 70 millimole potassium daily. Just if you like to read and check all this, they will give you 70 millimole potassium. Just you can check this later. Just to summarize, because it's too long and important presentation today, just I need you, as regards the physiology of potassium, I need you to remember these three tips. I need you to remember one cell, principal cell, and I'm collecting it up for hyperkalemia. I need you to remember one hormone, aldosterone hormone. I need you to remember one channel, sodium potassium channel. This is the most tricky on physiology of potassium control. And as regards symptoms of hyperkalemia, sometimes the patient can by dyspnea, nausea, vomiting, fatigue, weakness, chest pain, muscle paralysis, paresthesia, palpitation, muscle weakness, absent the breast tender reflex. All the symptoms maybe came with hyperkalemia. And we already summarized here a murder with tall peak T wave. Murder with tall peak T wave. Tall peak T wave, narrow pace. Tall peak T wave with narrow pace. Murder, muscle weakness, urine evaporation or anuria with respiratory stress, and decreased cardiac contractility with cardiac arrhythmia, ECG changes, and reflexes hyperreflexia with wide chorus complex. Just to remind you by signs and symptoms of hyperkalemia, muscle twitch, cramp, paresthesia, irritability, anxiety, decrease of blood pressure because bradycardia, ECG changes, dysrhythmia, abdominal cramp. Mungkin some patient came by abdominal cramp and diarrhea. And then this to remind you by normal potassium level 3 to 3.5 to 5 milliequivalent, and this is symptoms and signs as we discussed before. Normal potassium in your daily dietary intake of potassium around 80 to 120 milliequivalent or millimole per day, and fecal excretion around 10 milliequivalent per day, and 70 to 90 urinary excretion to alpha with potassium shift. And this will lead to a potassium shifted to intracellular by insulin, beta-2 adrenergic, salbutamol, and alkalosis, sodium bicarb. This will increase your potassium shift out the cells, acidosis, hyperglycemia, and alpha-adrenergic stimulus, exercise, and others. And it had mentioned the intake for potassium around 100 milliequivalent per day. Around 100 milliequivalent per day, and this our excretion around 100 milliequivalent per day, urine and stools. And this urine handling, this renal handling of potassium around 700 milliequivalent, 600 to 700 filtered load per day. We have proximal tubule reabsorb around 75 to 80 or 90% of potassium, and 25 by lobe of Henle, and 10% by distal tubules, as we clarify here. 60 to 80 reabsorption, 25 reabsorption, 10 reabsorption, the remaining will be by the collecting duct. And with here, just to increase this luminal flow rate, distal sodium delivery, aldosterone, all this will enhance sodium reabsorption and potassium secretion in different channels. Wink pathway, potassium and hypertension, as we discussed before, increase sodium reabsorption and distal convoluted tubules lead to hypertension, and also inhibited Wink kinase inhibitor Wink by withdraw from cellular membrane or cellular lumen of the cell to be intracellular, lead to no sodium, no potassium excretion. Renal handling, we saw this hyperkalemia when our patient reaches stage 4, if not diabetic. If a patient is stage 3 with diabetic or interstitial disease or drugs interfere increasing potassium, we can see hyperkalemia in stage 3 too. And this mechanism, we discussed different drugs lead to hyperkalemia. You can read also, I will keep for you. And these other causes of hyperkalemia is up to date. I will keep for you to read. And this already clinical manifestation we discussed, narrow-paced peak to wave, and flat or broad flat B wave, and prolonged BR interval, wide chorus complex, sine wave, asystole at the end. And the diagram to evaluate any patient with hyperkalemia, pseudo-hyperkalemia, potassium release from cells, as we mentioned before, hemolysis, from tourniquet. And this estimation of renal potassium excretion, we can use both potassium to create ratio. Treatment of hyperkalemia is emergency or no. If emergency, like muscle weakness, paralysis, cardiac abnormalities, arrhythmia, ECG abnormalities. Hyperkalemia with rhabdomyolysis. Prompt therapy is need therapy within 6 to 12 hours. Hemodialysis patient, just to give him medication until prepare for dialysis. Patient with marginal kidney function, with marginal urine output. Hyperkalemic patient need to be optimized before surgery. Any patient above 5 or 6 before any surgery. Slow lowering therapy outpatient. Slow lowering therapy outpatient. Not just in this outpatient clinic stable patient, not emergency. Hyperkalemic emergency ECG changes on potassium more than 6.5. Put the patient under monitoring, cardiac monitoring, and the crash cart handy if needed besides the patient, and give ECG stat for any patient with potassium more than 6.5. Stabilize the cardiac membrane and check the dioxin toxicity for this patient, just to give calcium gluconate, 1 to 2 gram IV push or calcium chloride by central line. See. Hyperkalemic emergency of potassium more than 6.5, shift the potassium glucose insulin, 50 ml, 50%, 10 units plus 10 unit insulin, regular insulin. Monitor blood sugar every 15 to 30 minutes for 2 hours to check risk of hypoglycemia. Beta agonist salbutamol inhalation 5 to 10 to 20 if you like to give, recommended lastly to give 20 milligram nebulizer. Can repeat if needed. Potassium removal from the body, kidney only when there is urine production. You can excrete by giving Lasix, whatever the dose, and normal saline to enhance urine excretion. Otherwise, we can give, if not emergency, we can give Kexalate, this calcium resign. This will bind the potassium from GIT, calcium resign or sodium zirconium calma or Bartumir, and we'll discuss this. Always ensure 3 things: there is renal function, pre-renal, give IV fluid, and if you obstruction, rule out any post-renal. If his renal function is okay, give normal saline with Lasix. If pre-renal, just give IV fluid again, and you can enhance this by Lasix. If you obstruction, rule out obstruction. And the specific therapy, dioxin specific VAD fragment. This patient severe dialysis toxicity is the main line of treatment. Relief of obstruction, if acute severe obstructive neuropathy, stop potassium supplement and drugs. This specific therapy you should check, especially if cardiac patient. Give dioxin specific VAD fragment as antidote for dialysis toxicity. My home message today: don't forget these 3 cells, principal cells, aldosterone hormone, sodium potassium ATPase channel. Please don't forget these 3 tricks. Okay, and with acute management of hyperkalemia, stabilize first your patient by calcium, as we mentioned before. Shift your potassium by insulin, as we discussed, 50 ml over 30 minutes. Beta-2 adrenergics, nebulizer 10 gram to 20 gram nebulizer. And now we have stabilizing, we have shift, we have GIT secretion, batyromir or sodium zirconium. The Localma, this is a very nice drug, but expensive. Zirconium, sodium zirconium, this Localma 10 gram BID if your patient waiting for dialysis, and hemodialysis if you have dialysis facility. And if your patient is good urine output, you should give him Lasix at least 80 or 120 if his blood pressure is too high. Chronic management, please, any patient in your clinic or your dialysis round review, just please check the medication that can, if you have polypharmacy for hyperkalemia, stop unnecessary medication, stop potassium drugs as if unnecessary, otherwise you can continue with life-threatening to your patient. But if it's cardioprotective like that, you just try to control the diet and your dialysis and try to do your best with your patient to protect his cardiovascular, to protect him from cardiovascular mortality. Calcium urine inhibitor also you should rule out, and because his mechanism of Wenke kinase activation of sodium chloride co-transporter channel distal convoluted tubules, and the careful drug history to rule out non-steroidal if your patient non-steroidal anticox. This prostaglandin inhibitor also decreases the distal flow of sodium to collecting duct. Dietary counseling, the most important in a patient with chronic hyperkalemia. Diuretic if a patient with residual renal function, medication, batorumir or sodium zirconium, localma, or cakes later you are available, just give with lactulose. And fludrocortisone if your patient with low effective arterial volume type 4 RTA, you can give 1 milligram daily. And sodium bicarbonate if your patient with metabolic acidosis as regard the chronic management if your patient is stable in your nephrology clinic. And don't forget this pamphlet for any patient with hyperkalemia and CKD in your clinic. And it again, just print and you can give to any patient came to your clinic. وبسم الله الرحمن الرحيم، وقل رب زدنا علما ويزدكم علما جميعا باذن الله. صدق الله العظيم. ولا تنسوا الصلاه والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. دي وصيه ليكم، ونسالكم دايما الدعاء لو حد استفاد شيء او استفاد معلومه يعالج بها مريض. نسألكم فقط الدعاء بالصحة والستر والعافية، ونلقاكم في موضوع قادم قريبا بإذن الله. ودايما أنا هركز على موضوعات الإمرجنسي، الموضوعات المهمة، وطبعا بركز على طبعا محاضراتي دي كلها الغرض منها طريقة العلاج وطريقة التشخيص كلينيكال وليس كعرض محاضرات أو عرض كلام ما منه فايده ولا تضييع وقت. انا عايزك توصل الخلاصه بتاعت الموضوع اللي انت بتقراه او الموضوع اللي انت بتسمعه، نطلع بفايده للمريض بتاعي في النهايه. ونسالكم الدعاء بالتوفيق والسداد. ولا تنسوا دايما الصلاه والسلام على حبيبنا محمد صلى الله عليه وسلم. ونلقاكم في موضوع مهم قادم قريبا باذن الله. والسلام عليكم ورحمه الله وبركاته.